right. So she is from Massachusetts and is currently a fourth-year medical student from Northwestern University. She got her undergraduate degree from Northwestern University, where she studied both biology and data science. As an aspiring urologist, she is interested in applying data analysis and visualization tools to help patients better understand their medical conditions and improve overall care. Please join me in welcoming Clarissa Wong.
Good morning, everybody. All right, so today I'm going to talk about exploring surgery for the treatment of metastatic prostate cancer. Our patient is a 69-year-old African-American male with a past medical history of type 2 diabetes, and he comes into clinic with an elevated PSA of 14.6. Now, this is his first ever PSA screening, and he comes in with no symptoms. He's voiding well, he has no gross hematuria, he denies bone pain, fatigue, weight loss. And additionally, he has no family history of any cancer. On digital rectal exam, he's found to have a 30 cc prostate and no nodules. Now, the trajectory of his disease escalates when 1 month later he returns to clinic and he's found to have a PSA of 24.4, increasing almost 10 points from a month prior. We start his workup. He's given a prostate MRI. He's found to have a PIRADS 5 lesion. And on prostate biopsy is found to have 4+4 and 4+5 Gleason grade group cores. Later, we perform a PSMA PET CT and a CT abdomen pelvis scan. And here's his MRI. As you can see, there's a lesion measuring about 3.6 centimeters from base to apex, essentially covering the entirety of the left peripheral zone. And to quickly review his PSMA PET CT scan, here we go. Now, as you'll see, he has distant metastases in the lungs, in the liver, to bone, and to his lymph nodes. So what the current dogma would suggest is that we need to treat him with systemic therapy, this being chemotherapy, hormonal therapy, or some combination of both. But recent research has showed us that perhaps adding a localized therapy, such as a prostatectomy or radiation therapy, could be viable and perhaps appropriate, maybe even beneficial for a patient like this. So the seed and soil hypothesis is this concept that was thought of by surgeon Stephen Paget in the 1880s. And I kind of spun it into my own analysis here. So imagine you have a dandelion, and a dandelion, if you leave it alone for long enough in your garden, it's going to grow and it's going to spread. And what's going to happen is that seed is going to spread and it's going to plant itself in the ground and it's going to grow in the ground wherever the ground will allow it to grow. And this is a big problem in your garden because eventually you're going to have a yard that is just full of dandelions that are really hard to pick out. And not only is the dandelion spreading, it's also growing. It's this primary dandelion, so to speak, is providing shade and nutrients for the other dandelions around it. So the longer you leave it alone, the more of a problem it becomes. And we can liken this to high-grade prostate cancer. Prostate cancer, if you leave it alone for long enough, is going to eventually spread to the bones, to the lymph nodes, and to visceral organs. And just like dandelions, they are fast growing and they are stubborn. Now, where the seed and soil hypothesis comes in is that this primary tumor is thought to be releasing these chemotactic cytokines that allow for, this appropriate microenvironment in other, bones, lymph nodes, other organs to properly foster an environment for growth of distant metastases. So what would happen if we remove the primary tumor? Would this slow down the growth of other distant metastases? Now, the consequences of this concept are monumental. And the reason for that is because right now, our standard of treatment is limited to systemic therapy. If a patient is diagnosed with metastatic prostate cancer, we have always thought that, your treatment has to be androgen deprivation therapy, it has to be chemotherapy. But what if we treat the offending primary tumor, and that actually affects the downstream metastases and can change the trajectory of the disease? So do we have data on this in regards to, the safety of performing surgery in these patients? Do we have data on the impacts of quality of life as well as survival? Now, before we review the benefits of undergoing a prostatectomy in metastatic prostate cancer patients, we have to look at the risks. And in this study, it was a review of around 100 men who underwent radical prostatectomy for metastatic prostate cancer. And what they found was that around 79% of patients had no postoperative complications. The most common complications were a blood transfusion, a lymphocele, anastomotic leak, and wound infection. When they compared this data to a meta-analysis of patients who underwent a prostatectomy for standard indications, they found that only lymphocele and wound infection complications occurred at higher rates in the metastatic prostate cancer group. Now, what this tells us is that maybe performing a prostatectomy is a feasible option for patients who have metastatic prostate cancer. One of the limitations of this study was the surgical variability. It was performed across multiple sites by multiple surgeons with different surgical preferences. So this included patients who underwent a robotic prostatectomy as well as an open prostatectomy. In our experience as an institution, we found that robotic prostatectomies have lower complications than open prostatectomies. And perhaps in a single institution that performed primarily robotic prostatectomies, maybe this complication rate would go down. We also have evidence that, of the surgery safety and feasibility in metastatic prostate cancer patients. The trombone trial looked at patients who had metastatic prostate cancer and randomized them to receive standard of care, which was ADT with or without docetaxel, and standard of care plus surgery. And what they did was that they looked at these patients 3 months after treatment and looked at their quality of life, incontinence, and sexual function. What they found was that quality of life and sexual function were pretty comparable between the two groups at this 3-month time point. And incontinence was found to be worse in the surgical patients compared to the standard of care patients, which is pretty on par with what we see with our patients who are treated for standard indications. Now, one of the limitations of this study, including the small sample size, is the descriptive statistics, which lacks the quantitative analysis. Additionally, the time course was pretty short term, and we find that patients who undergo prostatectomy for standard indications tend to regain continence over time. So perhaps if they stretched out the follow-up to 6 months, even a year, that these incontinence numbers would actually improve. So what data do we have on the long-term survival benefit for this procedure? So this study looked at 84 patients who had metastatic prostate cancer in a retrospective review. Out of those patients, 27 underwent radical prostatectomy and had androgen deprivation therapy, and the remainder were the control group who just underwent ADT. What they found was that factors associated with overall survival included the number of metastases, and what was associated with castration-resistant prostate cancer-free survival was the postoperative PSA. Now, when they looked at the survival rates in between the control and the intervention group, they actually found that there was no statistically significant difference in between these two groups. But we should note that one of the limitations of this study was that it's a retrospective review that was done in 2021, and they're looking at data, probably a decade or a year older, and surgical techniques at the time, as well as the modern innovations that have brought us to where we are today with the prostatectomy might yield different results in terms of survival benefit with adding a prostatectomy to systemic therapy. So current studies, as you've seen, are limited in their scope. They're retrospective, they're feasibility studies that are limited in their qualitative statistics, or they have small patient cohorts that leads to low statistical power. Now, this patient population is incredibly high risk, and a prostatectomy is a technically difficult procedure. Thus, the decision to perform a prostatectomy is one that requires robust clinical data in order to outweigh the risks from the benefits, or the benefits from the risks. Now, there are several ongoing studies that seek to address this, including our very own SIMCAP study at Yale. So SIMCAP, led by Dr. Kim, is looking into patients who have metastatic prostate cancer, and they are randomized to receive ADT with or without docetaxel, or a combination of this systemic treatment plus a radical prostatectomy. Those preliminary data regarding this study published in 2019. And what they found was that 68% of their patients in this cohort reached nadir after 6 months follow-up from surgery. What they also found was that there were similar complication rates between patients who underwent surgery in the metastatic group, as well as patients who underwent surgery for standard indications. Of note, patients who underwent major complications included one who had acute tubular necrosis requiring dialysis and one who died. So overall, prostatectomy was tolerated in this patient group, but in order to avoid major complications, we have to ask ourselves, what is the ideal patient profile who is going to undergo favorable outcomes? And how can we avoid major complications in the future by cherry picking patients who are best suited to undergo prostatectomy? So this study seeks to address just that question by using genomic analysis. They looked at patients who had metastatic or advanced prostate disease, and they found that 78% of patients were alive at last contact with a median follow-up of 42 months. They also estimated that 60% of patients, the survival rate at 5 years was 67%. Now, importantly, this study categorized patients into 3 different groups: favorable, intermediate, and poor outcomes. Favorable disease was categorized as a patient being free of disease and off of all systemic therapy for more than 2 years with normalization of serum testosterone. When they performed RNA sequencing analysis, they found that these patients had a downregulation of the TNF-alpha signaling pathway. And this is important when we think about, how we can pick our patients that are best suited to receive a prostatectomy. And it might not be all patients, but if we can pick these patients and know that they're going to undergo and experience a favorable outcome, then, that is an incredible stride in how we treat prostate cancer. So I want to go over this patient that I saw in clinic that is kind of a success story from SIMCAP. He was diagnosed with metastatic prostate cancer a few years ago, and his situation was quite dire. He had very high-grade disease that was diffusely positively metastatic in multiple locations. He was treated with systemic therapy, including relugolix, docetaxel, and darolutamide, after which he joined the SIMCAP trial, and he was randomized to undergo a radical prostatectomy. At follow-up, we saw him in clinic with his wife, and he said that surgery changed his life. It changed the trajectory of disease. He, was very happy with the outcomes, and his quality of life was remarkable. His PSA at 1.5 years, when we followed up, has been undetectable since he underwent the surgery. And it brings us to question, how many more patients can we positively impact with this research? In terms of future directions that this research will go in, there's there are currently ongoing clinical trials looking at comparing standard of care with radiation to standard of care with radical prostatectomy. In addition, it would be further interesting to look at subsets of metastatic prostate cancer, such as comparing oligometastatic versus widespread disease and seeing whether surgery has benefit in both or one. We can further look at larger multi-institutional clinical trials into the quality of life, functional outcomes, and cancer control. Overall, this is an area of research with a lot of different avenues, and as we continue to explore them, we'll learn more about how we can improve the treatment of this complicated condition.